This patient is a postmenopausal patient who's undergoing routine screening and mammography. She's not coming in with any symptoms. And unfortunately, like many of the breast cancers these days, they're detected by an abnormality that shows up on the screening mammogram. And that, of course, prompts a further evaluation with an ultrasound, and that looks at the breast and looks at the lymph nodes, and there's a suggestion of some abnormal lymph nodes. And then the patient's appropriately referred for a biopsy and undergoes a core biopsy that reveals a diagnosis of breast cancer. Now, this breast cancer undergoes the typical evaluation for both the hormone receptors, which this case was negative, and for HER2, which is standard for any new diagnosis of breast cancer, and that revealed that this case is a HER2 positive breast cancer. And so, at this point, we start thinking about what are the best treatment approaches for this patient. We look at the considerations of neoadjuvant therapy, adjuvant therapy, and really look at the guidelines. I think the NCCN guidelines really help us also try to figure out what's the next best steps for this patient to take. When we look at the NCCN guidelines and look at our postmenopausal 56-year-old lady that has a HER2 positive hormone receptor negative breast cancer, we look at a couple considerations for neoadjuvant therapy, and she presents with many of those findings. The current considerations for neoadjuvant look at tumor size and look at a tumor greater than 2 centimeters, and by imaging, her tumor falls into that category. There's also a suggestion of the involvement of lymph nodes. Now, she also did undergo an evaluation of a lymph node at the time of her breast biopsy. That did unfortunately reveal there was disease in at least one of the lymph nodes. So that's a patient that I would typically think of as a good patient for neoadjuvant therapy considerations. I think the guidelines would support that as well. And then looking at treatment options, we clearly think about dual HER2 targeted therapy with chemotherapy for neoadjuvant. And so in this particular patient, she received a recommendation of a taxane and platinum-based regimen with docetaxel carboplatin given concurrently with Herceptin and Perjeta, and then underwent surgery following completion of her chemotherapy. When we look at a patient that comes in post the biopsy, and we now have some parameters to start thinking of how we should best approach the patient, this patient clearly had the appropriate workup in terms of she had an imaging procedure that demonstrated a breast abnormality. She went on to an ultrasound that both looked at the breast and the lymph nodes. And so we really do want to get a look at that, the axillary contents, to start planning the strategy of a neoadjuvant or adjuvant therapy, and even considerations for the surgeon to explore sentinel node evaluation or full axillary dissection. So this patient's ultrasound did suggest a reason to biopsy a lymph node, and we have now documented lymph node involvement for this patient. And so this clearly, I think, guides us to the consideration of neoadjuvant therapy for this particular case. And then the considerations really are, what do we do in terms of systemic evaluation? So we now know the patient is a HER2 positive, lymph node positive, hormone receptor negative patient. And I'm already thinking of the strategy of neoadjuvant seems quite appropriate for this patient. But I do want to look at her systemic staging studies, because we know that this is a high-risk, highly proliferative, aggressive breast cancer. And it may have evidence of disease spreading. It's unlikely when a patient walks in, but I do consider doing both laboratory evaluation, looking at liver enzymes for the patient, and then I do like to go ahead and get a baseline systemic approach in terms of imaging, whether it's CT scans, PET scan, or a combination, to just take a look at liver, lung, and consideration of bones. The prognosis for this patient these days is fabulous. I think if we really look a little bit back in time before we had the real understanding of the HER2 signaling pathway, and more specifically drugs very specifically targeted for this pathway that are now part of standard care, the Herceptin and Perjeta in this case for the patient, I think we've taken what was previously really a very poor prognostic cancer that we knew had a very aggressive course, to now have such a tailored and directed specific HER2 dual targeted therapies part of the treatment approach has really now elevated the cancer to one of the cancers that has the best prognostic outcome if that disease is sensitive to treatment.